Okay. Hello, my name is Jessica Crimaldi. I'm a nurse practitioner working at the Cleveland Clinic in Cleveland, Ohio. I've been working in GI and hepatology, mostly inpatient, for about 10 years. I'm excited to be here today as part of the GAPP MASLD MASH Community Network, and we're going to be talking today about MASLD basics, or Metabolic Associated Steatotic Liver Disease Basics. There's my name. This is going to be the QR code that you can scan to record your attendance for the meeting, and we can always come back to this at the end if you don't get it now, but I'll just pause here for a moment. And if you would like to visit the GAPP MASLD MASH Community Network to view Madrigal MASH disease state education and Madrigal Resdifra promotional programs, you can also scan this QR code, and I'll pause here for a moment. Okay, so jumping right in to what we're talking about today, which is steatotic liver disease and the new nomenclature that you may have been becoming more familiar with or have been seeing more recently. Steatotic liver disease was chosen as the overarching term to talk about all things related to fatty liver, or in other words, all etiologies that can lead to fatty liver. So steatotic liver disease encompasses a lot of different types of fatty liver disease and a lot of different types of patient populations. All the way starting on the left over here, you'll see we're starting with metabolic dysfunction-associated steatotic liver disease, or MASLD, and metabolic dysfunction-associated steatohepatitis, or MASH. So MASLD and MASH have replaced NAFLD and NASH. We're changing the nomenclature from non-alcoholic to metabolic associated, just because that more accurately represents what's actually happening with the patients. And we'll dig into that a little bit more in the upcoming slides. In this large blue box, we touch on MASLD with patients who have increased alcohol intake. So you may be aware that excess alcohol intake can also cause steatotic liver disease, or excess fat in the liver. And the way to determine if somebody is more predominantly metabolic related, such as having metabolic syndrome, or more predominantly alcohol related fatty liver, is to quantify their alcohol intake. And you can see in grams their average weekly or average daily alcohol intake on a spectrum, and that will help you decide if they're more metabolic related, MASLD or MASH, or if they're more alcohol predominant, or ALD, alcohol related liver disease or alcohol liver disease. Patients who have both metabolic risk factors and increased alcohol intake, we would refer to as MET-ALD. Moving over to the small blue box, you'll see alcohol-associated or alcohol-related liver disease, or ALD. As I just mentioned, excess alcohol intake can cause excess fat in the liver, or steatotic liver disease. So this box is reserved for patients that do not have the cardiometabolic risk factors and are strictly just drinking too much alcohol and causing fatty liver. And then all the way on the right, you see these gray boxes. These refer to some less common disorders that can cause excess fat in the liver, such as like a drug-induced liver disease or liver injury, or things like HIV or even celiac disease. So this is kind of a miscellaneous category. And again, these are patients that don't have the cardiometabolic risk factors, don't have excess alcohol intake, but they happen to have excess fat in the liver because of some other condition. Now, to define MASLD a little bit further, so we start with steatotic liver disease. As I said, that's kind of the overarching term that we're using for excess fat in the liver. And typically one of the ways that we're finding this is it's identified on imaging or on a biopsy. Imaging can be for a liver-related concern or potentially a non-liver-related concern. So working in GI, it's very common that people come in, maybe through the emergency room, and they get a CAT scan of their abdomen or a right upper quadrant ultrasound, for abdominal pain or some kind of abdominal complaint, and we find fatty liver that they may not have known they had before. or somebody may have ordered imaging specifically for the concern of fatty liver. We're not getting too many biopsies these days, but you could also diagnose it based on a biopsy. So once you have concern for steatosis in the liver based on some kind of imaging or based on a biopsy that was obtained, you want to ask if the patient has any of the cardiometabolic criteria. You can see them on the right. We have the lighter blue box is the adult criteria, and the darker or medium blue box is the pediatric criteria. They are similar in what they contain, but they just have different reference ranges for the different age groups. But in general, you're going to have an elevated BMI or waist circumference, an elevated blood sugar or presence of diabetes, elevated blood pressure, elevated triglycerides, or a person is on lipid lowering treatment or blood pressure treatment, or just an elevated plasma HDL cholesterol, or a low plasma HDL cholesterol, or use of lipid lowering treatment. If your patient has any of these 5 criteria, you're going to follow over to the left side or the yes side, and then you want to think about, could they have any other causes of steatosis, such as alcohol, or one of the other conditions we talked about. If they don't, they are likely falling into the strictly MASLD box. If they do have excess alcohol or another concomitant disease process, they could be ALD, MASLD ALD, or a combination of multiple things. On the other hand, if you found fatty liver on imaging or biopsy and your patient doesn't have any of the metabolic criteria, you're again going to want to ask about alcohol or the possibility of other disease processes such as DILI, HIV, celiac, etc. And if they have those, then you would identify them in that way. And if we can't come up with any cause of it, then they may end up in this more rare cryptogenic category where we're not entirely sure why they have this steatosis. So just for your practice, how does the nomenclature and the diagnostic categories change your practice? So MASLD has officially replaced NAFLD, and MASH has replaced NASH. Studies do show us that there's about a 99% overlap between the patients that are currently defined as MASLD and the historical NAFLD population. So it should still be a similar group of patients falling into these categories. Any recommendations in the AASLD practice guidelines on NAFLD can be applied to patients with MASLD and MASH. And results from natural history and biomarker validation studies among patients with NAFLD and NASH are also just the same applicable to patients with MASLD or MASH. So you can think about these as being very interchangeable, but we do want to go forward with the new nomenclature. But understanding that older materials may still have NASH and NAFLD in them. So MASLD is hepatic steatosis, like we said, diagnosed on imaging or on biopsy, plus at least one of the cardiometabolic risk factors, or CMRFs. And like we said on the previous slide, it's going to be a BMI greater than 25, or an increased waist circumference above 94 centimeters or 37 inches in men, or 80 centimeters and 31.5 inches in female. They could also have a fasting glucose greater than 100, or a hemoglobin A1C greater than or equal to 5.7, or a known diagnosis of type 2 diabetes. Third criteria is a blood pressure greater than or equal to 130/80, or they're already on treatment for hypertension. Fourth criteria is triglycerides greater than 150, or they're already on a lipid lowering medication. And then lastly, we have our low HDL less than or equal to 40 for men, or less than or equal to 50 for women, or again, on a lipid lowering medication. This does exclude patients with alcohol consumption greater than 20 grams per day for women and 30 grams per day for men, because as we know, if they're more alcohol predominant, they fall into that MET-ALD or separate category. But they could still also have underlying cardiometabolic risk factors. So what do we do in the primary care office if we suspect steatotic liver disease? So your first assessment could be a FIB-4. For those of you who are not familiar, FIB-4 is a simple calculation you can do online. There's numerous calculators you can plug the patient's information into, and it requires pretty readily available information. So you need the patient's age, their AST, their ALT, and their platelet count, all of which you should be able to get on a CBC for the platelet count and a CMP or a hepatic function panel for the liver-related labs. One note of caution, because age is included, people that are younger than 35 or older than 65 may be slightly less accurate, because the younger than 35 population is obviously going to have a lower number going into the equation, where the over 65 is going to have a higher number, and that will affect their end result FIB-4 score, either pushing them towards a lower score or pushing them towards a higher score. So the score less than 1.3 excludes advanced fibrosis. A score in between 1.3 and 2.67, further investigation is warranted and fibrosis may be present. And then a score greater than 2.67, advanced fibrosis is likely. So your goal in primary care is really to identify patients who may be at risk. So here we are, we're suspecting that somebody has steatosis, maybe because they have diabetes or because they were in the ER and their CAT scan for abdominal pain showed fatty liver, and they also happen to be obese. So you're, wondering if this could be a possibility. First, you're going to calculate the FIB-4 score to try to determine where do they fall on this spectrum as, unlikely to have fibrosis, fibrosis is possible and we should look into this more, or very likely that they have advanced scarring. So based on the FIB-4 score, if they are greater or equal to 1.3, so they're out of that low risk, low suspicion, you want to reassess a FIB-4, if they're under 1.3, you want to reassess the FIB-4 score every 1 to 2 years if they have diabetes or 2 or more of the cardiometabolic risk factors, or every 2 to 3 years if no diabetes and less than 2 cardiometabolic risk factors. If their score is greater than or equal to 1.3, then we want to think about what is their risk, and you can further classify that by getting a transient elastography, or what we also refer to as FibroScan, or an ELF. An ELF is a proprietary blood test that you can order, and you will get a return score. And you can see the scores listed in the chart here that will classify your patient again as low risk, indeterminate, or high risk for having advanced fibrosis and stiffness. This little arrow just kind of highlights if they're low risk, you can go back to the top box and continue monitoring based on their diabetes and metabolic risk factors. If they're high risk or indeterminate risk, we want to think about referring them to a liver specialist, a hepatology provider, because these are patients that we consider to have at-risk MASH or possible cirrhosis, and they need more close monitoring. Another reason to refer to hepatology is if somebody's FIB-4 from the get-go is greater than 2.67. So that's when advanced fibrosis is likely, or if they're having persistently elevated liver function tests. All right. So thinking about that patient that is indeterminate or high risk of fibrosis or advanced liver disease, they do require specialty management and secondary risk assessment. So if you've obtained, we want to think about liver biopsy in a few situations. So if you've obtained a FIB-4 and perhaps an ELF or a FibroScan, and the results are discoordinate, meaning potentially the FIB-4 says, greater than 2.67, advanced scarring, cirrhosis is probably likely, but then you get the FibroScan and it's less than 8, and that would suggest not significant advanced fibrosis. Or if your NITs are all coming back in the indeterminate ranges, you may want to consider a liver biopsy. Also, if the diagnosis is just uncertain, this is where clinical judgment comes into play. If it doesn't seem to be adding up or quite fitting the picture, you may want to think about a liver biopsy or a patient who is having persistent enzyme elevations. Okay. And after you've done the liver biopsy or clarified their staging further, if they're stage 0 to 1, you want to reassess about every 2 to 3 years. Stage 2 to 3, reassess annually and consider possible pharmacotherapies to help with the excess fat in the liver and fibrosis. And then stage 4, we move on to that cirrhosis-based management where we're doing things like screening for esophageal varices, screening for hepatocellular carcinoma, monitoring and treating, ascites, encephalopathy, lab derangements such as hyponatremia, etc. Again, ELF is another score that we can use to help determine fibrosis in the liver. It's a proprietary blood test. And if that score were to come back positive at 11.3 or higher, you would really suspect cirrhosis, and then you would want to refer them. And also, if your clinical exam is suggesting cirrhosis, then you want to think about referring them to a liver-related provider. This is the global epidemiology of liver disease or steatosis. I apologize. Can I pause and just redo this slide?
Sure, okay. That's fine. Go ahead.
Okay, I'm just going to pause for a second. Let me grab a drink while I'm doing that. Okay, this slide shows us the global epidemiology of steatotic liver disease, and you can really see that most areas are not even below 25% is about the lowest, and that's Western Europe. And areas with the highest incidence are going to be Latin America at 44%, North America, where we are predominantly at 31%, parts of Africa at 36%, Southeast Asia, 33, South Asia, 33, Australia, Asia, 31. Okay, and then the natural history of steatotic liver disease, MASH, MASLD related in the United States. So currently we have about 60 to 80 million Americans who have MASLD. About 15 to 20 million of those actually have MASH. So 20 to 30% will progress over 3 years to fibrosis. So moving to the middle of the screen, that brings us to about 13 to 16 million patients with stage 1 to 3 fibrosis. Again, another 20% of those patients will progress over 2 years to stage 3 or cirrhosis, and that leaves about 1.2 million patients with cirrhosis. 30 to 40% of patients with cirrhosis will unfortunately die from liver-related deaths. The patients, going back to the left, the small blue circle with MASH, the 15 to 20 million, and then the ones that progress to fibrosis, the 13 to 16 million, and then the ones that develop cirrhosis, 1.2 million, are all at risk for developing hepatocellular carcinoma, which can lead to need for liver transplant or liver failure and liver-related death. Fibrosis progression rates in MASH are about 1 stage per 7 years, but 20% of patients are fast progressors and will progress to cirrhosis in 10 years. So MASLD initiation and progression. All the way on the left, we have a normal appearing liver. And then as we move right, we first develop steatosis or excess fat in the liver, which can be associated with inflammation. And as that continues, we progress into furthering fibrosis stages. F1 to F3 are considered fibrotic, where F4 is cirrhotic. So that's why it moves to its own category, where the liver is very stiff and scarred at that point. And then also we have an increased risk of HCC. I want to highlight the pinkish arrow underneath the liver chart, which lists obesity, diabetes, metabolic syndrome, and alcohol use. So your environmental factors, your weight, your diabetes control, the amount of alcohol you intake, all affect how quickly or slowly this can progress. So uncontrolled diabetes, excess alcohol use, uncontrolled weight, all will help advance the liver towards the right side of the screen, increase fibrosis and cirrhosis, as well as gut microbiome bile acid alteration. And we know that the PNPLA3 gene is a major driver of MASH, MASLD, cirrhosis, and HCC in patients who are susceptible host in conjunction with these other factors as listed on the arrows. The AASLD guidance from 2023, just want to highlight a few key points. MASH plus F2 to F4 fibrosis equates to a higher risk for liver-related events and mortality, and we refer to this population of patients as at-risk MASH. Rates of fibrosis progression and hepatic decompensation depend on the baseline severity of the disease, and then as we stated in the previous slide, genetic, individual, environmental, and comorbid disease determinants. CVD or cardiovascular disease and non-hepatic malignancies are the most common causes of mortality in patients with MASLD without advanced fibrosis. So these are the patients that just have the steatosis but not advanced stiffening. And death from liver disease predominates in patients with advanced fibrosis, which I think is not surprising. Okay, now we're going to go through what I would consider to be a pretty typical patient case. So this is JP. He's a 55-year-old white male and his BMI is 35, and he was referred for elevated aminotransferase elevations. He does have some right upper quadrant discomfort, and he's had 20-pound weight gain over 5 years. We have mostly quote unquote normal liver chemistries over the previous 5 years, but he has had some mild intermittent elevations with an ALT of 45 and an AST of 50, which are probably just above some of the standard cutoffs, and a normal ALP and TB, or total belly. His past medical history, not surprising, is obesity, 230 pounds with a BMI of 35, pre-diabetes with an hemoglobin A1C of 6.3 and high blood pressure. He does not have any family history of known liver disease. And social history, very rare alcohol consumption. He works in IT. Don't want to presume, but that may be more of a sedentary type job. And he does take lisinopril for blood pressure. And his exam does note some central adiposity, with his waist circumference being a little bit high at 110 centimeters for a male. We do want to review medications that could be contributing to steatosis in the liver, or steatogenic medications and potential other etiologies, as we've touched on before. So you can see amiodarone, methotrexate, tamoxifen, 5-FU, steroids, valproate, and antiretrovirals are ones that we commonly think about. And then we always want to make sure we're not missing another diagnosis that could be contributing to this. So things such as viral hepatitis C, Wilson's disease, lipodystrophy related to HIV, celiac, or some malnutrition starvation issues. Post-Whipple's, a patient who is on TPN can commonly develop steatotic liver disease. Metabolism errors. So there is, we always want to make sure we're doing that other checklist to make sure that we're not missing anything. So this is the workup for Mr. JP, and I just want to go through what we are typically checking when we are looking at chronic liver disease serologies. So like I said, even though he's sounding a lot like a MASLD or MASH patient, we do want to make sure we're not missing any other viral, genetic, other disorders that can cause liver disease. So first we would check viral hepatitis serologies. We're mainly here looking for the presence of chronic hepatitis B and C. We do typically also check hepatitis A, but that's usually an acute infection and would not lead to chronic liver disease. Next, we're going to check iron studies. So ferritin, transferrin, saturation, all of our iron panels can help give us a clue to possible hereditary hemochromatosis. Generally speaking, if the ferritin is significantly elevated, you may proceed to further testing with an HFE to check for that genetic marker. Just as a note though, ferritin can also be elevated in acute inflammation as well as excess alcohol intake. So that's where reviewing the history and understanding what's been going on has been helpful. AMA is a test that we can use to screen for PBC, or primary biliary cholangitis, which is a bile duct disorder. A celiac panel, we would also want to check for an ANA, or an anti-nuclear antibody, and an ASMA, or anti-smooth muscle antibody, both of which are screening tests to help diagnose autoimmune hepatitis. Alpha-1 antitrypsin deficiency can lead to both liver and lung-related problems. We would want to screen for a decreased level. You can also check genetic testing for that. Wilson's disease, I don't think is mentioned here, but screening for ceruloplasmin, low ceruloplasmin, and serum copper can be helpful in diagnosing that. And then we also just want to look at more rare things like HIV, alcohol screening use with PEth, and then the cardiometabolic risk factors such as the cholesterol, diabetes, and then routine labs such as a CBC, CMP, and INR can be very helpful. The main things I go to on the CBC is going to be looking for low platelets, which can be indicative of portal hypertension. CMP, you'll obviously get your liver biochemistries, and then an elevated INR can allude to liver dysfunction. Also have to keep in mind if patients are on warfarin, it may be elevated. If we're dealing with any kind of malnutrition where they may have a vitamin K deficiency, it may be elevated as well. So it needs to be taken into context. So these are the labs that were reviewed, and then this is his ultrasound. So ultrasound-based imaging does only detect moderate to severe steatosis, just be aware. So if patients have more mild or minimal steatosis, it may not show up on an ultrasound. So JP's ultrasound does show increase in hepatic echogenicity with the typical regions of focal sparing. So he has some areas that are not involved with the excess fat. The contour does appear smooth. The spleen size is normal. And the overall impression is hepatic steatosis, no evidence of portal hypertension. So based on this ultrasound with a normal spleen size and a smooth appearing liver, we can be fairly confident that advanced fibrosis, cirrhosis, or portal hypertension are not present. And then which patients still need a biopsy? And then these are some slides of actual liver biopsies here and the difference. So you'll see some more in the bottom. The blue tissue represents more scarring and fibrosis. So if patients have stage F2 versus F3 and your non-invasive biomarkers, again, such as your FIB4, your transient elastography, or your ELF are giving you different results, you may want to think about a biopsy, or if they're older in age. And again, we always want to rule out any other etiology that could be contributing to liver disease in general or steatosis. So for our patient, we did diagnose the steatosis on imaging with that right upper quadrant ultrasound that showed the smooth liver, but the increased echogenicity with focal sparing, which can be a finding of steatosis. And then he also has some of the metabolic criteria, right? So he has an increased BMI and waist circumference. He's on lisinopril for hypertension. So he has some of the features as well as, that pre-diabetes diagnosis. So following down to the left side, he does have the cardiometabolic criteria. And we didn't go through all of the labs here, but we did not identify any other causes of steatosis for him. So we can safely label him as MASLD, or the Metabolic Dysfunction-Associated Steatotic Liver Disease. And the main thing we want to know now, so we can be pretty confident that he has MASLD, does he have any underlying steatohepatitis? Does he have any fibrosis? And specifically, does he have advanced fibrosis? And that's where those non-invasive tests come into play, specifically like transient elastography and FIB4, and potentially biopsy for some patient to help categorize how advanced they are, or how at risk they are for developing progressed liver disease. Okay, that was our last slide. Thank you very much for listening today. Again, I was happy to be a part of this GHAPP MASLD MASH Community Network. We'll be doing some more talks in the future, but I hope you found this helpful.